It's my pleasure to introduce Dr. Daisuke Tomizawa from Japan, who will tell us about AML treatment in the Asian view. Dr. Tomizawa.
Okay, thank you very much for inviting me to this wonderful meeting at Moscow. Today's my topic is AML treatment in the Asian view, but I would like to focus on our Japanese experience, how we have developed the standard care for children with AML. So this is this slide shows the treatment guideline of the Japanese Society of Pediatric Hematology Oncology for childhood AML. And I suppose that this is how it looks like in many other countries as well. As shown in this slide, we have approximately total population of 120 million people, and population of children under 15 years old is 60 million. And annual incidence of childhood cancer is 2,500, and that of childhood leukemia is approximately 700. As a result, we have approximately 180 childhood AML newly diagnosed cases per year, and 30 Down syndrome AML, and 10 APL, and 140 de novo AML cases. First of all, I would like to focus on Down syndrome AML cases. As all of you know, Down syndrome patients with AML, patients are relatively young, usually age under 5 years old, and usually they have a megakaryoblast morphology as shown in this slide, and also they have a mutation in GATA1 gene on chromosome X. In terms of the treatment, Down syndrome AML blasts are very sensitive to chemotherapeutic agents, including especially cytarabine. At the same time, Down syndrome patients are very vulnerable to chemotherapy, and usually, if they are treated with a very intensive chemotherapy, the toxicity rate would be very high compared to non-Down syndrome patients. Therefore, it is very critical to establish low-intensive Down syndrome-oriented chemotherapy. This is chemotherapy which was used in the previous AML-99 Down syndrome study. This chemotherapy is very low-intensive, and this does not include any high-dose RSC or continuous dosing of RSC. And with this therapy, we produced 80% of event-free survival and overall survival with no early death and only one death in CR among 72 patients enrolled. However, once Down syndrome patients with AML relapse, their outcome is very, very poor. This slide shows the outcome of 26 relapse and 3 refractory AML Down syndrome patients who were diagnosed originally between 2000 to 2010. Their CR rate was only 50%, and their overall survival was 25%. And what is very important is that allogeneic stem cell transplantation could not alter their prognosis. So the main question for Down syndrome AML would be how could we identify patients with poor prognosis and prevent treatment failure? Because as I said, once they fail, there is no treatment which could overcome their poor prognosis. One answer might be the detection of MRD and stratify patients with MRD detection. There are several methods for detecting MRD in Down syndrome AML patients. One might be flow cytometry-based MRD. One might be detecting mutated GATA1 gene by next-generation sequencing. And one might be detecting WT1 expression. In the recently completed Down syndrome AML study in Japan, namely AML-D11 study, we have tested 3 kinds of MRD methods. One is flow, another is GATA1, and another is WT1. At this moment, I don't have any results that I could present here, but I suppose within several years, I think we could present some of the results from this study. Next, I would like to move to the acute promyelocytic leukemia. APL used to be one of the most difficult subtype of AML because of severe coagulopathy and bleeding. However, due to the introduction of combination chemotherapy with ATRA and chemotherapy, APL became one of the most highly curable disease among all the AML subtypes. Here we show the recent results of our APL study. We have 83% event-free survival rate and 90% overall survival rate. In 2013, there was a very striking paper published in New England Journal of Medicine. This is an adult study, adult APL study, testing, randomizing patients to receive conventional chemotherapy combined with ATRA, or to receive ATRA combined with arsenic trioxide. What was striking is that patients who were randomized to ATRA arsenic arm did very well. Their survival rate was excellent, with very limited toxicity. So in the current ongoing Japanese childhood APL study, namely AMLP13 study, we substitute 3 courses of conventional chemotherapy course to the 3 courses of arsenic trioxide therapy. For the poor responding patients, we introduce gemcitabine azithromycin. I'm pretty sure that arsenic is very effective for childhood APL also, but we have to be very cautious because at this moment we don't have any long-term outcome, including late effects for children with APL. So I think this arsenic trioxide should be used in the setting of clinical trials. Finally, I would like to move on to de novo AML. So the major concepts of pediatric AML studies in Japan is to improve the outcome of children with AML by adopting better risk stratification, reducing the cumulative doses of anthracyclines to avoid late cardiotoxicities, and intensify post-remission therapy with high-dose RSC instead. And lastly, limiting the indication of allogeneic transplantation in first remission to avoid late transplant-related late effects. This scheme shows the study AML 99, which accrued 240 de novo AML patients between 2000 to 2002. Patients were first allocated to one of the 2 inductions according to their age and white count. And after initial induction therapy, patients were stratified to one of the 3 risk groups. Patients with low risk and the intermediate risk patients with matched sibling donor received total 6 courses of intensive chemotherapy. Intermediate risk patients with matched sibling donor and all the high risk patients received allogeneic bone marrow transplantation in first remission. The results of this study is shown here. The overall survival rate was 75% and event-free survival was 61%. The succeeding study, JPSG-AML-05 trial, was the first all-Japan AML trial for children with AML. In the previous AML 99 study, 3 out of the 4 major leukemia study groups have joined. But in this AML-05 study, all 4 leukemia study groups were merged together as a single national leukemia study group, the Japanese Pediatric Leukemia Lymphoma Study Group. The main study objectives for each risk group is as follows. For the low-risk patients, to evaluate the efficacy of post-remission chemotherapy consisted of total 5 courses with reduced cumulative doses of anthracyclines and tococyte. For intermediate-risk patients, to evaluate the efficacy of the post-remission chemotherapy consisted of total 5 courses without allogeneic transplantation in first remission. For high-risk patients, we evaluated the efficacy of allogeneic transplantation in first remission. Total 443 eligible patients are accrued. this study. So this is the scheme of the AML-05 study in comparison to AML-99. The induction therapy was united to one single ECM. This is consists of a continuous dose of RSC, etoposide, and mifepristone. And after 2 courses of the chemotherapy, patients were divided into either of the 3 risk groups. And the major change was we put the first 3 ITD patients was included in the higher risk criteria. And total therapy course was reduced to 5 courses from 6 courses. And what is important is that for the low-risk patients, we have reduced the total amount of anthracyclines from 300 milligram per square meter to 225 milligram per square meter. And allogeneic transplantation was indicated only for high-risk patients. So this slide shows the 3-year event-free survival and overall survival of AML-05 study. Event-free survival was 54%, which was inferior to the previous AML-99. However, overall survival was 73%, which was almost the same with the AML-99 study. The reason for inferior event-free survival was the inferior event-free survival in the core binding factor AML patients. The result was 68% compared to 80% in AML-99 study. However, the overall survival was the same. From these results, we concluded that even in the core binding factor AML, which is thought to be favorable, at least 300 milligram per square meter of anthracycline is necessary to maintain a good event-free survival. For the non-core binding factor AML patients, event-free survival and overall survival was identical between the 2 studies. As I mentioned, in the AML-05 study, first 3 ITD patients was included in high risk, and they were to receive allotransplantation interest remission. This strategy was partly successful because nearly 70% of the patients who achieved CR and received transplantation survived. However, substantial number of patients could not achieve CR, and their survival rate was only 28%. So the event-free survival and the overall survival of total FLT3 ITD patients was 36% and 46% respectively. So we concluded that to truly improve the patients with FLT3 ITD, we need to introduce a novel therapy such as FLT3 inhibitors. In the current ongoing study, AML-12, we are evaluating the role of a high-dose RSC in first induction, and we are trying to establish flow-based MRD system. And also we are trying to evaluate the role of reduced intensity stem cell transplantation for high-risk patients. And for the risk stratification, we have added several new prognostic factors for high-risk patients. And this slide shows the outcome of 11q23 MLL gene rearrangements in pediatric AML. This work was done by the International Retrospective study by the International BLM Study Group. As shown here, patients with translocation gene 1011 or translocation 611 have very poor prognosis compared to other subtypes of AML. So given these results, we have included translocation 611 patients in our new high-risk criteria. Other risk factor we have included in our high-risk patients, NOT98 and SD1. This fusion is produced by the cryptic translocation 511, and this is associated with normal karyotype and French American British morphology of M4 and M5, and they have very poor prognosis. Even among the FLT3 ITD patients, patients with NOT98 and SD1 has poorer outcome compared to NOT98 and SD1 negative FLT3 ITD patients. And one of the major points that of this AML-12 study to introduce the flow-based MRD system. This survival curve shows the results of the add-on study of flow MRD to the previous AML-5 study. And what is interesting is that presence of flow MRD both after induction 1 and after induction 2 clearly separated the patients with poor prognosis and good prognosis among the intermediate cytogenetic patients. Our flow-based MRD system is done centrally in 2 centers. One is BA University and one is in Kyoto University. And this MRD system is done in cooperation with Dario Campana and Elaine Christensen-Smith in Singapore. So this is the overview of our JPLSG AML-12 study. So patients are randomized to receive either standard ECM induction or high-dose ECM, which includes C. And after 2 courses of induction therapy, patients are allocated either of the 3 risk groups. And for the binding factor patients, since the event-free survival in AML-5 score wasn't good, we put an extra course of chemotherapy as we did in AML-99. And flow MRD is measured after induction 1 and induction 2. So this table shows the recent results of pediatric AML in Japan and in the US and in Europe. Although we have achieved more than 55% event-free survival and nearly 70% overall survival, relapse and refractory disease are still the major issue in pediatric AML. So as Jeff mentioned in the first talk, the development of novel therapy is necessary. So these are my collaborators. And большое спасибо.
Questions for Dr. Tomizawa?
I'll ask you one question. So if we compare straight the Japanese results with, for example, St. Jude's results or BFM results, there is a slight difference in favor of European and American results regarding the event-free survival. As far as I can calculate, it's about 8 to 10%. Could it be due to this decreased doses of anthracyclines? Because in our experience, we also tried to decrease the doses of anthracyclines in our protocols, but it resulted in more relapses than in BFM-like protocols.
Your question is?
So the question is the inferior results of Japanese studies compared with the BFM or American studies. Aren't they due to the decreased doses of anthracyclines that you're investigating?
Well, I suppose that the problem with AML is that there's a very, very few effective anti-cancer drugs for APL. So always talking about anthracyclines, RC, maybe plus minus etoposide. So that's why if we reduce one element, even in what we think is good risk patients, their survival risk goes down. So I think several groups, especially adult studies, have shown that adding gemtuzumab to azithromycin could improve the results of the CBFA. And also maybe like adding gemtuzumab could enable to reduce anthracyclines. So I think currently St. Jude is testing clofaramin in their study. So I think in their first induction they are randomizing clofaramin plus RC and RC plus anthracycline. So that adding something and reducing anthracycline is I think one way to reduce the cumulative anthracycline.
What is the current dose of anthracyclines in your protocol now?
So in our protocol, for patients who are on the standard arm, it's a randomized study between daunorubicin, etoposide versus fludarabine and cytarabine during induction 1. So for patients who are on the standard AD arm, they receive 300 milligrams per meter squared of daunorubicin and 36 milligrams per meter squared of mitoxantrone. So it's a large dose of anthracycline.
Do you see, sorry, very nice presentation, congratulations, very well put together, very nice data. Do you see difference in terms of, you talk about the recombinations, in particular the ones that are associated with poor prognostic, and the question is probably also to Jeff, do you see the same kind of bad recombinations associated in other populations in the United States, or is that something primary in the Japanese population?
Sorry, I don't know if I get your question right. So the combination difference?
The chromosomal, the recombinations at the chromosomal level, the 610 or 611, I think was the one that was associated with poor prognostic. Is that right?
Yes. I'm not sure I'm not sure about the difference. I think we didn't see that difference from our results.
Thank you.
Are FLT3 inhibitors available in Japan?
Some of it is under development, but actually most of the so-called FLT3 inhibitors, for example, sorafenib, is only indicated for solid tumors. So that makes it very difficult for us to use in leukemia because since we have a universal healthcare system and unless the company completely provides the drug while we buy the drugs by the grant, it is very difficult to do the clinical trials using off-label use of these kind of drugs. And currently, a new type of dual inhibitor, FLT3 inhibitors are under development in adult AML, so maybe in future we will be able to use that drugs. Yes, so it's currently under development.
And in your treatment, your protocol for APL, you divide patients according to response to therapy. Do you still use, in the past we used white count to diagnosis. Do you no longer use white count to stratify APL patients?
Actually, what is different from a European study and our study is that we stratify APL patients by the response of the chemotherapy, not white count or age. So that's why we couldn't eliminate the first two courses of chemotherapy to arsenic. But maybe in the future, I think all the chemotherapy was eliminated by arsenic and ultra, or maybe plus gemcitabine for a high-risk patient. Thank you.
How do you treat isolated myelosarcoma?
Myelosarcoma. Thank you. Very nice question. Actually, in our clinical trials, myelosarcoma patients are not included, so I don't really have exact results for the treatment outcome of myelosarcoma. However, I think most of the centers in Japan treat
Myelosarcoma.
Yeah, myelosarcoma. I know. Are treated with usual chemotherapy, and maybe I think some institution uses local radiation therapy as well. But mainly with systemic chemotherapy.
What is criteria of remission for this patient?
Criteria for remission. So, as I said, myelosarcoma patients are not, they're not eligible in Japanese AML studies, but in the practice level, I think most of the institutions take the imaging studies such as CT or MRI, and I think they define the remission by both bone marrow findings and also the imaging studies.
And what do you think about preparation for transplantation for these patients?
Well, I think if the response is very good, I don't think transplantation is necessary for these patients because I think one factor is that many of the island sarcoma have a translocation 821 who has a very good prognosis. So I think you should determine the indication of RSCT by the treatment response.
I have a question. All your studies have very categorically said about de novo AML. Does your approach, or do you have a separate studies for secondary leukemias?
Your question is, does we have secondary AML?
Secondary AML, do you put them on a high risk protocol, or is there a separate?
Okay, thank you very much. Actually, secondary AML cases are not included in the study, so they are treated as a practice base by each institution. But usually, I think most of the secondary AML patients go to transplant if they get remission.